Morning, everyone. My name is Dr. Dindayal, and we are here from Neurology. I'd like to thank you for joining us. And I want to introduce one of our senior neurology registrars, Dr. Motsilili. He'll be taking us through a group of conditions that was once considered quite rare, but now with increasing ICU capacity has become not uncommon and very relevant to us here at the GEN particularly. So over to you, Dr. Motsilili.
Good morning. Thank you, Dr. Dindayal. My topic today will be weakness in the ICU, a practical approach. So these are the headings which I'll be discussing this topic. Go through the definition, look at the risk factors, pathophysiology, the clinical approach, and the management. Thank you. So
please speak up a bit.
Okay. So ICU acquired weakness can be defined as a clinically detected weakness in critically ill patients in whom there is no plausible etiology other than critical illness. And then those patients with ICU acquired weakness are then classified into those with critical illness polyneuropathy, critical illness myopathy, or critical illness neuromyopathy. And that those patients with critical illness myopathy are further subclassified histologically into cachectic myopathy, thick filament myopathy, and necrotizing. So what are the risk factors for developing this condition? They usually divide the risk factors into non-modifiable risk factors and modifiable risk factors. So under non-modifiable risk factors, there are those risk factors that fall under the severity of illness, such as those patients who have a higher illness severity score, with systemic inflammation or sepsis, multiple organ failure, prolonged mechanical ventilation, prolonged critical illness, and high lactate levels. Then under the demographics, which also falls under non-modifiable risk factors, we have female sex, older age, premorbid obesity. So they found that a higher risk for ICU-acquired weakness may apply to women more than to men and to older patients as compared to younger patients. Then premorbid disability and frailty may predispose to the severity of weakness, and that premorbid obesity was found to be an independent protective factor against the development of ICU-acquired weakness and against the development of muscle atrophy. Then under modifiable risk factors, we have hyperglycemia. Patients who have had prolonged or severe hyperglycemia while ICU stay. And also parenteral nutrition, where they've said that late initiation of parenteral nutrition might be associated with faster recovery and fewer complications. So some say not earlier than 4 or 7 days. It differs as you read. Then we also have drugs, which include vasoactive medications, corticosteroids, neuromuscular blocking agents, combined with corticosteroids, especially if infused for more than 48 hours, and certain antibiotics. So under certain antibiotics, they have aminoglycosides and Vanco. They've also included other potential antibiotics that may increase your risk of developing ICU-acquired weakness, such as clindamycin, erythromycin, quinolones, polymyxin or polymyxin, tetracycline. But independently, so far, we're not sure whether these are associated with ICU-acquired weakness. Then lastly, under modifiable, we have those patients in the ICU that have had prolonged bed rest and immobilization. So what is the pathophysiology? Let's first look at the critical illness polyneuropathy, where it is primarily a distal axonopathy or an axonal process. So with all those risk factors that we've covered, you'd find that there's now reduced oxygen and nutrient delivery to the actual nerve axon through macro and micro circulatory impairments, caused by myocardial depression, vasodilatation, hypotension, endothelial dysfunction that leads to activation of the coagulation system with resultant luminal obstruction, increased permeability, tissue edema, and impaired mitochondrial function. Then other postulated mechanisms include release of low molecular weight neurotoxins that injure the axon, such as lipopolysaccharide, interleukin-2. Also, the contribution of hyperglycemia that also adds to axonal injury. Also, neural membrane inexcitability through increased sodium channel inactivation. Then when we look at the critical illness myopathy, we find that there's also reduced membrane excitability, altered sarcoplasmic reticulum function, decreased contractile protein function, mitochondrial dysfunction, bioenergetic failure. Then you also get muscle denervation through either pharmacological or structural mechanisms, so secondary to developing the critical illness polyneuropathy that would lead to denervation and then critical illness myopathy. Then you also have muscle atrophy that could be a result of increased proteolysis, decreased protein synthesis, and increased apoptosis. So this is just basically a diagram depicting what I've tried to summarize in the previous slide. So I won't go through it really. But just an example that when there's critical illness, then the cytokine production. So if you go to far left, then this will lead to electrical alterations, nerve membrane depolarization that will contribute to critical illness polyneuropathy. That then leads to muscle denervation, contributing to critical illness myopathy. But basically, there's an interplay of various mechanisms there. Right. So what is the clinical approach to ICU acquired weakness? I think it's important initially to consider some scenarios in which weakness can or may occur in the ICU, in that this could be a primary neurological disorder that the patient is having, or it could be an acute exacerbation or a progression of a pre-existing neurological disorder, or it could be a direct complication of the ICU stay, including the treatment and any other underlying medical conditions. So it's important to go through the CNS peripheral nervous system, so brain, brainstem, spinal cord, nerve, neuromuscular junction, and muscle, and consider all the potential etiologies that can affect either one or more of these areas. So it's important to carry out a careful review of the patient's notes, discuss with the ICU staff, for example, who know the patient, telephone call the family to gain more collateral history. Then it is suggested that usually a neurological assessment should take place when sedation has been withdrawn. Some authors suggest after 5 half-lives of that particular drug. Then when we come to ICU acquired weakness, it usually presents beyond the first week of ICU stay. So what we find is that patients have a generalized, diffuse, and symmetrical weakness that usually spares the cranial nerves and is associated with failure to wean, or there's dependency on mechanical ventilation. Then as you assess further, those patients with critical illness polyneuropathy, you'd find that they have respiratory weakness with distal muscle weakness, as it is an axonal problem. And you'd also find that the sensory impairment with absent or retained deep tendon reflexes, depending on the progression. Then for critical illness myopathy, you'd find that there's respiratory weakness with proximal muscle weakness, with normal sensation, and absent or retained deep tendon reflexes, also depending on the severity. Then if a patient's got critical illness neuromyopathy, then you might find proximal and distal muscle weakness, distal sensory impairment with absent or retained deep tendon reflexes. But it is said that CIP, CIN, and CINN may have similar presentations that cannot reliably be differentiated clinically. So after doing this assessment, so initially, before we move forward to quantifying the muscle strength, usually I've seen that they like, for example, comparing critical illness polyneuropathy and GBS, which could have perhaps a similar presentation. So let's just look at some of the common things and some of the different features of each. So we've covered the prodromal conditions for CIP. Then for GBS, we know that usually there's, as due to gastrointestinal, a trigger is gastrointestinal or respiratory infection. So usually we see this patient usually presenting before the ICU admission. So there's usually an infection that precedes the onset of the condition. And then they'll say that frequently cranial nerve is involved. There is cranial nerve involvement. Then on the CSF, we see critical illness polyneuropathy, usually it is normal, while in GBS you could find albumiноcytologic dissociation. Then on electrophysiological studies, you'd find an axonal pattern for CIP, while for GBS you could find a demyelinating pattern, but you could also find an axonal pattern. Then on the MRI for GBS, you could find occasional enhancement of the spinal nerve roots, while for CIP, there are usually no significant findings. Then for biopsy, if it's GBS, if it's a demyelinating subtype, then you'd find those findings. Then the treatment is obviously different. You think for GBS, then go to plasmapheresis IVIG. Then they both have basically variable outcomes. So after you've assessed your patient, think that they have ICU acquired weakness, then your next step would then to do a clinical assessment to quantify the muscle strength. So I found that the MRC sum score and the handheld dynamometry are found in some of the diagnostic criteria. So these are required, some diagnostic criteria, but we'll just look at some of them that are there. So you have the volitional function test, which is said to measure the strength and the endurance of the respiratory system and the limbs. Then we have the MRC sum score, which I've mentioned is a gold standard, that assesses the strength of each muscle group in the upper and lower limbs, with scores for each muscle group ranging 0 to 5. So 0 is the worst total, where 60 is best. So advantages of this is that it is non-invasive, so it's a bedside testing. They found that there's excellent inter-rater reliability, excellent accuracy in diagnosing weakness. But then, for example, the disadvantage is that it may be affected by positioning of the patient and the availability of the actual limbs for assessment. So the limitation include things such as pain, dressing, or any other immobilizer devices that the patient might have. And that also there's a lower sensitivity in patients who have more subtle change in muscle function. So instead of having 4 minus, 4 plus, for example, then you have to grade between a 4 and a plus. Then there's also been found that one of the disadvantages might have weak correlation with physical function. Then there's an MRC sum score, which has 4 categories, but has not been validated. So I won't go through that. Then we have the handheld dynamometry, which assesses the hand grip strength. So it's a quantitative measure, non-invasive, quick and easy bedside testing. Also high inter-rater reliability and high sensitivity and specificity. But they found that one of the disadvantages that some of the patient might find the test very hard, so that they might tend to score low for this, and that they're uncertain whether it is representative of the global muscle strength. Then there are other tests that have been looked at, such as the scored physical function intensive care test, functional status score for the ICU, the Chelsea critical care physical assessment tool, and the 6-minute weight test. Then after looking at clinical, then you could look at then you proceed to do an electrophysiological assessment, where a complete nerve conduction study and EMG is a gold standard. So the advantage that it can be applied to unconscious, uncooperative patient, that is the nerve conductions study, and that the limitations include electrical interference and tissue edema. Then patient cooperation is required for the EMG part of it, for voluntary muscle activation. Then they found that in some patients, you could decide to do a single nerve conduction study, such as a peroneal nerve test, instead of doing the full, which it is said that it is 80% specific for diagnosis of ICU acquired weakness, but then it also suffers from similar limitation to a complete NCS EMG. Then there's also direct muscle stimulation test, which does not require patient cooperation. It is minimally invasive, and that usually in CIP would show that there's no more muscle excitability, while in critical illness myopathy, it shows reduced muscle excitability. However, the expertise are not widely available. And then this said that the diagnosis is made further complicated by the co-occurrence of both CIP and CIM. Then it may also be limited by electrical interference and tissue edema. I want to go through the findings. Then imaging that one could consider is an ultrasound, which is said if you want to measure muscle quantity and quality, but it may underestimate muscle and protein loss. Then one could consider CT and an MRI, which can accurately and reliably detect infiltration of muscle by adipose tissue and quantify the fat-free muscle mass. Then other tests that one can consider: dual energy X-ray absorptiometry, neutron activation analysis, and bioelectric impedance measurements that measure the body composition of the patient. Then on biopsy, so nerve and muscle biopsy actually allow differentiation between critical illness polyneuropathy, critical illness myopathy, and their subtypes. And that it is an invasive procedure with the potential for complication and requires specialized expertise for obtaining samples and interpreting the findings. So nerve biopsy is said to be too invasive for routine clinical use, and hence it is no longer advised, except in the context of scientific research. But what would you find if you were to do these? So in critical illness polyneuropathy, your nerve biopsy would show axonal degeneration, like mentioned, of distal motor sensory nerves. Then a muscle biopsy in CIP would show acute degeneration with atrophy of type 1 and type 2 fibers. Then a muscle biopsy for critical illness myopathy. So there are all the different subtypes that you can find: critical illness myopathy, thick filament myopathy, necrotizing myopathy as well. So it is said that in critical illness myopathy, you'd find that there's loss of myosin, so the thick filaments with varying degrees of necrosis, with 5 type 2 fast twitch fiber atrophy. Then other features of actually this critical illness myopathy type is that they say that some of the patient could have a normal CK, and that usually the prognosis is good, and that it could represent a hypercatabolic complication of sepsis or SIRS. Then we have thick filament myopathy, which is associated with selective loss of myosin filaments or thick filaments. So in these patients who have thick filament myopathy, they say that CK may be elevated, and it is often associated with high-dose corticosteroids and neuromuscular blocking agents, and that it has a better prognosis than necrotizing myopathy, of which we'll look at next, of which you'd find that there's prominent myonecrosis along with vacuolization and phagocytosis of muscle fibers. So these patients may progress to frank rhabdomyolysis. You also find that the CK is frequently elevated. Then here usually it's predisposed by, so there's often a history of being non-septic and placed on high dose corticosteroids, neuromuscular blocking agents, or both, and that the prognosis is poorer than the other two subtypes. Then I read that there's also cathectic type of myopathy, so I'm not sure if it fits under one of these, where they say they typically have normal CK levels, essentially normal electromyograms, and the histological findings are limited to only type 2 fiber atrophy, where there's no myosin loss. Then we have critical illness neuromyopathy, where the nerve biopsy would show an axonal degeneration of distal motor and sensory nerves, and that the muscle biopsy, usually in mild disease, is usually normal, but in severe disease can show generalized necrosis with loss in myosin with type 2 fiber atrophy. So what is the diagnostic algorithm and criteria? I apologize if you can't see properly. I'll just brush through it. So it's important initially to interrupt the use of sedatives and analgesics. And then you reassess the patient and see whether are they awake and able to follow commands or instructions. Then if they're not able, then you continue to withhold the sedative or analgesics. Then if they still remain unresponsive, then it's when you proceed to consider tests such as CT brain, MRI of the brain, EEG, and CSF studies. Then in those patients that are awake after interrupting sedatives and analgesics, then you proceed to assess the MRC score. Then in your assessment, if you find focal deficits when a patient is responsive, then if it's a CNS problem, then you proceed to assess CT brain, MRI, etc. But then if it is a peripheral nerve deficit that is asymmetric or focal deficit, if it's peripheral nerve, then you still do an NCS, EMG, and muscle biopsy. Then for those with symmetrical weakness, then you proceed to do MRC SAM score. Then those that score less than 48, you proceed to do serial examination. Also the assistance of occupational therapy. Then if there's no change in the condition or there's further deterioration, then you proceed to do an NCS, EMG, and muscle biopsy. Then in those patients that improve, then you do physical and occupational therapy and you observe. So then just below just highlights once you do the NCS, EMG, muscle biopsy, then depending on the findings, then you look at whether do your patients fulfill the diagnostic criteria. So what are the diagnostic criteria? So the initial is to look for ICU acquired weakness, where there's a minimum requirement. So there needs to be 1, 2, 3, or 4, and 5. So what are these? So a patient needs to have generalized weakness that develops after the onset of critical illness, that the weakness is diffuse, involving both proximal and distal muscles, is symmetric, flaccid, and generally spares cranial nerves. Then 3 or 4, you find that there's MRC SAM score of less than 48, or a mean MRC SAM score of less than 4 in all testable muscle groups, noted on 2 or more occasions, separated by 24 hours, and that there is dependence on mechanical ventilation. Then the cause of weakness is not related to the underlying critical illness. Then those patients that meet the diagnostic criteria for ICU acquired weakness, you then further then decide whether this is polyneuropathy, myopathy, or neuromyopathy. So for polyneuropathy, they need to meet the criteria of ICU acquired weakness. They need to have specific axonal features or findings on nerve conduction studies, which is a compound muscle action potential amplitude less than 80% of the lower limits normal in 2 or more nerves. Also sensory nerve action potential amplitudes that are also decreased. And that to make sure it's not a demyelinating process, they need to have a normal or near normal nerve conduction velocities without conduction blocks. And there needs to be absence of decrement response on repetitive nerve stimulation. Then for critical illness myopathy, they also need to meet the criteria for ICU acquired weakness. Then they can fall under the probable and definite, depending on how many of these points that they fulfill. But then also you need nerve conduction studies, which show that they have sensory nerve action potential amplitudes that are more than 80% of the lower limit of normal in two or more nerves, and that the needle EMG in two or more muscle groups demonstrate short duration, low amplitude motor unit potentials with early or normal full recruitment with or without fibrillation potential. Then you have the expertise for direct muscle stimulation. It would demonstrate reduced excitability muscle nerve ratio of more than 0.5 in two or more muscle groups, and that muscle histology needs to be consistent with myopathy. Then the diagnostic criteria for neuromyopathy is basically as features of between the two, so I won't cover that. Then I think I included the slide because it included the hand grip dynamometry scores as well, in addition to the MRC sum score, where it says that for males, those patients that score less than 11 kilograms and 7 kilograms for females as well. And that there's also an entity that includes diaphragmatic weakness as well. So what is the management and prognosis? So they said that early treatment with IV diagnosis of sepsis has been suggested and examined in a few small studies. But however, because it's believed that this is a toxic insult, rather than being immune-mediated, it is not recommended as a treatment. Then they've also looked at recombinant activated protein C. It has been shown to reduce morbidity and mortality in septic patients. However, its role in ICU acquired has not been specifically addressed. And other initially promising pharmacological interventions include anabolic steroids, oxandrolone, growth hormone, propranolol, and glutamine therapy. However, currently there is no evidence to justify their use in routine practice. Then there's also neuromuscular electrical stimulation. But however, most recent systemic review and meta-analysis did not reveal significant improvement in muscle strength or dependency on mechanical ventilation and intensive care with this, as compared with usual care. So it's also not necessarily recommended. So treatment is still supportive with the emphasis on prevention, and that the prevention and therapeutic measures include aggressive treatment of sepsis, avoiding hyperglycemia by strict glycemic control, avoiding early parenteral nutrition, as during the first week, minimizing sedation, encouraging early mobilization, and early rehabilitation. So the prognosis, recovery usually occurs within weeks or months, although it may be incomplete, with weakness persisting up to 2 years after ICU discharge. And that it appears compromise the prognosis when the cause of ICU acquired weakness involves critical illness polyneuropathy, whereas isolated critical illness myopathy may have a better prognosis. Then it might have a significant contribution in some centers, this entity of ICU acquired weakness, meaning that there should be future research that focuses on preventative endotherapeutics strategies on this condition. Thank you.